Good morning, everyone. Thank you so much for coming. We're so pleased to have this kind of a turnout today. Today we announce the release of recommendations by the Bipartisan Policy Center's Future of Healthcare Initiative. For 3 years, my colleagues and I have worked to find common ground to make health insurance more accessible, more affordable for all Americans. My fellow co-chairs, Gail Walensky, Andy Slavitt, and Bill Frist, and other members of our group, Sheila Burke, Jim Capretta, Chris Jennings, Cindy Mann, and Avik Roy, are here this morning to release our new report. And this is a copy, and it'll be made available. If you don't have it, you'll have it before you leave. Our copy of the report, which includes recommendations that we believe can serve today as a roadmap for compromise. Before we discuss those details, I want to take a moment to remember our colleague, Alice Rivlin, who is also a member of this group. Those of you who knew her will see her influence throughout our recommendations. Alice was known for her dedication to health policy solutions that were fiscally responsible. At the same time, Alice was committed to solutions that made health insurance available and affordable to those with pre-existing conditions. She is deeply missed by all of us and by healthcare and budget leaders alike. It is difficult to remember a time in recent history when we have been more divided by our country. It's that divide that extends especially to healthcare. But one issue that unites us around healthcare is our great concern about growing costs and the need for Congress and the President to act to provide meaningful relief. A recent BPC poll that we took verified that affordability was the driving issue for the American public, and it should be policymakers' #1 priority today. Indeed, nearly twice as many voters said they wanted to improve the current healthcare system as said they favored either Medicare for All or repealing or replacing the Affordable Care Act. My colleagues and I understand the underlying philosophies of both sides who advocate for significant change. However, we firmly believe that policies securing bipartisan support are most likely to stand the test of time. So we came together around 5 principles that form the basis of our recommendations. First, all individuals should have meaningful and affordable public and private health insurance. Second, health reform should be designed to avoid major disruptions because many patients rely on today's long-standing arrangements to get their needed care. Third, insurance markets should be stable, not endangered by premium increases due to adverse selection or insufficient pooling of risk. Fourth, health reform should reduce excessive and unnecessary growth in healthcare costs. And fifth, reform policies must be politically and financially sustainable over the long term. We recognize the congressional leaders and the administration officials who have already reached across the aisle to find thoughtful solutions to our affordability challenge, such as surprise medical bills and increasing pharmaceutical costs. But we recognize that failure to address healthcare affordability with other interconnected challenges such as food insecurity, housing instability, and other social determinants of health will continue to limit economic opportunity for our country. So based on our principles, we've incorporated many of these bipartisan ideas into our recommendations today. But ultimately, we believe that more can and should be done to make health insurance more affordable, and we believe these recommendations can help provide a policy roadmap to bipartisan action. Gail?
Thank you very much. Good morning. I'm here joining my colleagues today in releasing the bipartisan recommendations that are designed to address the rising cost of health insurance, to lower prescription drug costs, to stabilize the individual insurance market, and to end expensive surprise medical bills. In health reform, as in other policy areas, Republicans have sought market-based solutions whenever possible to, in this case, address the rising costs of health insurance and to increase and to be able to protect against increasing out-of-pocket costs. In recent years, Republicans have supported market-based solutions, including income tax credits for the purchase of health insurance, health savings accounts, and shifting away from value-based to value-based reimbursement in Medicare and Medicaid, as well as increased state flexibility for Medicaid. The recommendations that we've released today include many of these ideas. At the same time, it's important that we analyze markets and understand the limits of market-based solutions where markets are dysfunctional. Those of us who believe in the importance of maintaining a robust private health insurance market, for example, understand that pure market-based solutions would result in avoidance with significantly higher premiums or coverage denials for those who are predictably high-risk individuals. Without health insurance, these individuals may fail to seek medically necessary care, or in extreme cases, as we have read about in the media, have medical bankruptcy. To address this limitation in the market, we have supported policies such as guaranteed issue, state-based auto-enrollment options, modified community rating to help markets function in a way that meets the public policy goal of making sure that insurance is accessible. Market failures, which we understand exists, need to be addressed when hospital consolidation has thwarted competition and excessively increased prices. We seek to address these costly anti-competitive behaviors, and to do this, of course, we need to make sure that access remains for needed care in rural communities. Our policies do that. I, along with Senator Daschle and Chris Jennings, are members of another BPC effort, which we'll be meeting later this week, to address the need to improve access to care in rural areas, and you will hear more from us when the report is released in April. Finally, it's critical that for healthcare providers and consumers to move away from our historical system of payment, which rewards volume over value of services, a concept that we have heard repeatedly in the last few years. Payments to providers, hospitals, and clinicians, and nurses as well, need to encourage high-value services and promote improved outcomes. Managed care is one way of achieving that goal, but of course it's not the only way. Other promising payment models are being developed, and health policy needs to incentivize movement into these model payments for providers and consumers. Policies such as building on all state all-payer claims, databases, and reforming the Stark and anti-kickback statutes will help accelerate the movement toward value-based purchasing. The package that is being released today represents both Republican and Democratic ideas. It represents 3 years of negotiation, and I'm hopeful it will help policymakers move forward in the coming months and years to find bipartisan agreement. Andy?
Thank you, Gail. Good morning. Thanks for joining us today. You know, an interesting thing about bipartisan solutions, they're where nobody starts. They're nobody's favorite ideas, and they're not what anyone runs on elections on anymore. But in this day and age, they are what gives Americans more confidence in the system and more confidence in their government. The most frequent question I get asked in the real world, I live in Minnesota, it's the real world, is can there ever be bipartisan agreement again on health care? We really want it. Well, we did it with criminal justice reform. Someday we'll do it with immigration, and maybe someday we'll do it with healthcare. A year from now, whoever is the president will have a narrow or divided Congress to deal with. So we believe these recommendations are all the more salient. As my co-chairs have described, getting a gang of 10 together with really pretty divergent views was a good microcosm of what a Congress would do if they decided to get serious about this issue. It could even be a good blueprint. I think the package we came up with reflects some things. First is what is the art of the possible? What ideas can you stomach in exchange for other ideas to be included? What places do we agree but actually use divisive language that makes it seem like we don't? As Senator Daschle noted, to the credit of many in Congress, we include many of the ideas that are currently being debated in the Congress and ideas that have been put forward by the administration. Ending surprise medical bills, lowering prescription drug costs should be passed, even in what many to consider to be too modest forms under which they're being considered, because the agreement would be durable. And we will take durable over perfect. I hope election year politics don't get in the way of those. There are a number of provisions we agreed to in our gang that are not being considered in a bipartisan way at this point, but which improve upon the ACA and the safety net and fix some of the unintended consequences. It would have the effect of lowering insurance costs for millions and extending subsidies to the middle class. Here we have the American public on our side. They would like to see Congress get together and pass bills that make the healthcare system work better and finally reject the notion that the ACA should be a continued politically charged litmus test. Reinsurance is not a partisan idea. Neither are cost-sharing reductions for low-income Americans, or restoring marketing to bring in young, healthy populations and bring the cost down for everyone, or expanding open enrollment. These points will bring costs down for the subsidized and unsubsidized portion of the individual market. We know that the cost of insurance premiums, prescription drugs, deductibles, or other out-of-pocket costs are too high. In particular, the burden that falls on middle-income Americans who are not eligible for premium assistance. They often face very high premiums they can't afford and deductibles causing them to remain uninsured or to forego medical care altogether. That's why increasing premium tax credits and reducing premiums to families with incomes up to 600% of poverty, which is roughly individuals with incomes up to $75,000, family of four, $150,000, is currently being proposed in the House is so important. Bringing down costs is what Americans really want, not simply subsidized premiums. So the ideas that Gail laid out to tackle some of the excesses in the system from over-consolidation and excessive pharmaceutical pricing is fundamental. While it isn't easy, doing what people across political philosophies believe to be right for the American public ultimately proved to be the underlying theme of our work. If our project had a flaw, compared with how Congress approaches these issues, we were not under the constant and relentless pressure of special interests and party leaders. We were left alone, free from that influence, seeking input from experts, listening to public sentiment, and paying attention to our own conscience. Needless to say, when Congress faces times of crisis or problems it is committed to solving, instead of exploiting, it can do the same thing. I want to offer my great thanks to the BPC staff, first of all, for their amazing work, and to all of my colleagues who worked on this, particularly those that listened patiently through my belligerent and pig-headed moments. I also wish to echo what Senator Daschle said and deeply thank and honor Alice Rivlin. She always reminded me that we could do what we could do if we put our country first. Thank you.
Our work on this proposal together not only shows these problems can be addressed, but demonstrates that people with varied political and policy interests can work together to find agreement if, and really only if, they are willing to put the health of the people first. We humbly agree that there are many, many different paths to get to this end point. There are many different paths besides our proposal that you could get to that end point. But our experience over the last 3 years of working together has absolutely convinced us that if members are of both parties coming together in the same room, and if they reject political polarization, and if they embrace the notion of bipartisan compromise, they can secure those healthcare policy advances that in truth rationalize our healthcare system and benefit the very people that it serves. I'd like to stress that these recommendations do not represent the least common denominator of policies. I think my colleagues would agree that while some of the recommendations can stand alone as bipartisan solutions, for example, both parties are working to end surprise medical bills, to look at issues about bringing down prescription drug costs. But many of these recommendations were hard fought amongst the 10 of us, back and forth, and took more than, I would say, a little bit of political courage to agree upon in the face of what we have as respective parties. One example is the need to find a rational way to reform the tax treatment of employer-sponsored health insurance. We offer in the proposal, in the plan, what we believe is a reasonable policy in the wake of overwhelming bipartisan support for repeal of the so-called Cadillac tax on employer-sponsored health insurance. As the largest federal tax health expenditure, an estimated $173 billion last year in 2019, we simply can't afford to ignore this as we seek to incentivize the lower health care cost. Recognizing today's polarized political environment, our approach has been to construct and to build upon the current public-private system and offer policymakers today an alternative to, on the one hand, repeal and replace the ACA, and on the other, Medicare for all. We've designed the proposal to be fiscally responsible. These recommendations encompass changes that would increase in some areas federal spending and reduce it in others. Overall, it is the intent and expectation of the experts participating that the plan should modestly improve the government's fiscal outlook. The policies recommended here could be adjusted to achieve this goal. In the coming months, indeed, we will be working with modeling experts to finalize the distributional and cost estimates. Ultimately, we believe that Congress can reach a bipartisan deal on health care reform if they reject political polarization and lead with improvements to our current system. That's the message of our new report released today by members of the Bipartisan Policy Center's Future of Healthcare initiative. Now I invite my fellow members of the group to the stage, Sheila Burke, Jim Capretta, Chris Jennings, Cindy Mann, Avik Roy, for a discussion about our recommendations. Please come forward and we'll take our seats.
Thank you all again for joining us today for what I hope will be a very engaged conversation with each of the panel members about the aspects of the proposal that's been described in sort of the opening remarks. I think importantly, as Senator Frist noted, the recommendation contained in our report do not represent the lowest common denominator. Our deliberations were not without strong disagreements of opinion. Not unlike the discussions taking place on the Hill or with the folks down Pennsylvania Avenue. The politics clearly played a role in our discussions. The group is made up of individuals, as is evident, with a long history of very divergent views in terms of the issues we were trying to address. Differences of opinion on the role of the federal government, differences of opinion on the role of states and of individuals, views on markets and competition, views on the responsibility of individuals in that decision making. We did not set aside those views, but clearly sought to find middle ground, to find areas of compromise. There was no disagreement on the need to address costs, as has been noted. No disagreement about concerns about affordability and access, and no disagreement over the challenges that prescription drug prices bring, nor the damage that surprise medical bills pose for families. What we can do, and what we hope to be able to do in this report, is to address those issues in a way that lays a groundwork for going forward. Are there differences among us in the solutions? Absolutely. But the belief in the need for a bipartisan solution which can stand the test of time, as Senator Daschle outlined and as was noted, it really isn't trying to reach the perfect, but trying to reach the possible in the solutions, drove us towards trying to find compromise. No one changed their colors coming in the door, but we worked to leave some of those differences at the door as we came together over this period of time. So it was a long 3-year process, and as Ovik noted and as Andy noted, the staff deserve an enormous amount of credit for managing us, which is not an easy process, but to driving us to essentially come to closure. And so we are gifted with them to support us. We're going to begin a process where I'm going to ask some questions of the panelists for a bit and ask them to comment on some aspect of the proposal. Everyone received a card when you came in the door. If you didn't grab one, we'll give you one, on which you can write questions. We will come to a period of time where I will open it up for audience questions, both either at the mic or on the questions. So I would encourage you to do that. And we will hopefully finish up by having answered some of your questions and hopefully having drawn some conclusions about what it is that we are in fact proposing. I'm going to begin by asking Senators First and Daschle, who have on more than one occasion found a way to come to the middle to try and find compromise, to give us their thoughts in the midst of partisanship, particularly over health care, some of which we heard last night in the President's speech. There seems to be a call nonetheless for building on the existing system. And certainly our polling suggests that that's where the majority of people would like to go. It's an election year, and so I might ask them how they think we can find a pathway to some kind of compromise in the months that we have remaining yet this year, and establish essentially that you can build on the system without having blown the entire system up. So I'm going to ask them what's that pathway and how best to address it.
Well, I'll jump in. So both Tom and I are from a different era, as you all know, in terms of the United States Senate as a manifestation of the country and Congress. But I think that together and the people before you really do believe in this day and time, this is not crazy, this is not outlandish, that we have an opportunity, and maybe even a greater opportunity because of what we see in this external world, the fact that we were able to come together. So I would say just the sort of 3 things. Number one, overall bipartisanship is not absolutely dead. If you look just in the Health Committee, you had 2 people, Lamar Alexander and Patty Murray, who did 3 big pieces of legislation in the last 2 years. You can start with 21st Century Cures, a big higher education bill, the opioid legislation. I mention that because it's not no bipartisanship there. That's not the case. There is some. Number 2, I would say we need to build on that. And you build on that by identifying individuals in the House and the Senate and in the administration around issues that you've thought about and that you've cultivated and that you've debated and you compromised on. And then the third point is we're sort of halfway there now. Right now we have debated, talked about, compromised, put things on paper, and the process now is really cultivating, educating with what we've learned. And then this little period of now in the elections is an ideal time to begin that cultivation process.
Well, not surprisingly, I agree with everything Bill just said. I think I would just simply add to that, that I think it's important for us to remind all of our policymaking colleagues that there is a cost to doing nothing. And that cost across the board, whether it's related to health costs or quality or access, go up with each passing year. So the more we delay, the more costly all of this becomes. And so those incremental steps that Bill outlined, I think, are so critical. And what we have to do is be persistent. We have to continue to find ways to create venues for dialogue. I think below the surface, there are indications that those dialogues go on, but we ought to do more of that and continually ensure that these proposals that we work so hard to produce get the kind of attention they deserve. And it's probably too trite, but certainly true, that we have to remind our colleagues, and we all fall victim to this sometimes, not to make the perfect the enemy of the good. There is a lot of good in what we're proposing. There are incremental steps that can go a long way to addressing those costs if we do nothing.
So I'd like to dig into some of the elements of the proposal which we've not had a chance to really talk about. And one of the areas that is likely to receive a fair amount of attention and around which there is likely to be a fair amount of discussion is the suggestion with respect to market consolidation. There are provisions included in our recommendations as to how best to address that and also what the implications are in the context of consolidation. When economists say that half of the hospital markets today are highly concentrated, what does it mean? How do we measure that? How do we think about the implications of that? And I'd like Ovik and Chris Jennings to perhaps address that as two who were particularly engaged in that conversation. Ovik?
Thanks, Sheila. First of all, let me just say what a great honor and privilege it's been to be a part of this group, to learn from people like Tom Daschle and Bill Frist and Alice Rivlin, who I grew up learning from and reading and watching. In terms of this particular idea, it's been great to see how this is something that we originally proposed in 2014, and see it evolved and refined by this group is very interesting. And the way I'd basically summarize it is it's basically auto antitrust. So there's been, over the last 25 years in particular, as managed care started to course through the system in the 1990s, the big response of hospitals was to merge and consolidate and create regional monopolies to fight off managed care and say, if managed care is trying to, say, we don't want you to do this, or we want you to avoid this high-cost service, or we want you to keep your prices down, hospitals merged and consolidated to basically rebut that and say, we're going to dictate what the prices are going to be. And there's an enormous amount of academic research now that shows that in more concentrated hospital markets, prices of hospital care are higher. And those price increases have nothing to do with the underlying cost of delivering those services. It's simply that regional monopoly has more market power and can charge more to the consumer, to the insurer, to the employer. So how do you solve that? In theory, the Federal Trade Commission, the Department of Justice have already the power to break up hospital monopolies, but they don't use it for that purpose. They're very reluctant to break up existing consolidation, and the courts have often sided with hospitals and sort of bought the argument that, well, these mergers are really not going to affect consumers. That's starting to change. But a big part of this idea that we're proposing in this report is to use common measures of market consolidation. One is called the Herfindahl-Hirschman Index, which I won't bore you with an exact definition of, but it's widely used by antitrust economists to measure market concentration, to say if there is a regional market for hospital care which is extremely consolidated, so 2 to 4 times more consolidated than what the FTC and DOJ normally go after, that in those markets, hospitals would have to accept Medicare Advantage rates, the local Medicare Advantage rates from all payers, private insurers, commercial insurers, et cetera, individual market insurers under the ACA. And what that does is it basically puts a cap on the ability of hospitals to consolidate simply for the purpose of raising prices, which most mergers are about. And it also creates, actually even more importantly from my standpoint, a powerful incentive for those large regional hospital systems to break up into smaller units. So they're, again, competing with one another on price and quality and value for the patient. So if you're the kind of person who doesn't want to see a system in which there is Medicare for all or a single payer or some other federal regulation of prices across the spectrum, This is a way to restore a more competitive market where hospitals are fighting with each other over quality and price and value.
I'm going to ask Chris to comment as well, and note that one of the concerns that was raised during the course of our discussions was the likely consequences on the closure of hospitals. And there was a particular concern with rural areas, given what we've seen in terms of trends in the closure of small hospitals across the country. But Chris?
Sure. Thanks, Sheila, and again, for all my colleagues, it's been wonderful working with you, and I wish this was coming to an end, but I have a feeling we're going to continue to be working on this issue for a while. I think Gail mentioned a little bit earlier that we're working on a rural health access issue, and it's something that, you know, I look at Senator Daschle and Senator Friz, that there is never an issue that comes up around healthcare in which rural is not mentioned or raised. And there, of course, when you have a rural area, you're not going to have multiple hospitals, so by definition, you do have market consolidation in those areas. And indeed, we've seen substantial, very, very high rates of reimbursement in those areas. Sometimes we do, sometimes we don't. But in any case, we can't risk losing access to those facilities. People can't go hundreds of miles to get care. So our specific policy just exempts basically large thresholds of providers in those areas because we believe there needs to be a separate approach to dealing with rural areas. The predominant problem, both in terms of the cost, the overall cost of healthcare, it's where most people are living in urban areas, is the consolidation in those markets in which there's consolidation and there's excessive prices well and above anything that you would otherwise expect. And that the purchasers, particularly commercial purchasers, private insurers, either have been unable or they simply cannot secure lower rates. And in fact, if you look at the reimbursement rates that we're seeing in these areas are 200, 300% of the Medicare rates. At some point in time, what we're seeing is the employer community is really raising these questions about the disparity between public purchasers and private purchasers. And they're looking at these markets and they want to see some sort of incentives to change more towards a little bit more market leverage for the purchasers to be able to do better in these areas. And I think, and really Ovik is the intellectual father of this policy, which means that if there's any controversies, we like him to defend them. And there will be. But we think it's a very constructive policy to engage in this important discussion because the issue that's driving our healthcare debate is this whole issue of cost and complexity. It's what the public and the employer community is facing in terms of their unsustainability and unaffordability of healthcare. And if we don't start addressing this issue, and we can't just do it through subsidies, we can't just keep on throwing money at this problem to reduce the out-of-pocket costs, we're going to have to address the issue of cost. And part of the issue of cost is price. And this is what this policy is designed to do.
It leads into the next question, which is something that Andy touched on, and that is our recommendation with respect to the subsidization of individuals into the private marketplace and how best to utilize that tool. There is a lot of discussion about the need to stabilize the marketplaces and the individuals and how they essentially respond to that. And we have proposed in the report increasing the number of individuals and families who are eligible for support. I wonder, Jim, if you would touch on that issue and the importance of that, and also the question of auto-enrollment, which also came up. That is, how do we make sure that people are involved in the system? But let's talk, and I would encourage the rest of the group to feel free to comment as well. But I want to talk a little bit about that because it's something that hasn't been done, something that's been discussed in the past. Why hasn't it in fact come to fruition, and what in fact are we planning, and what is it that we hope we result in?
Sure. Well, thank you. I'm also pleased to be part of this group. It's been a long process, but I think we've come up with something that has been described well as not the lowest common denominator, but the path of feasible. I mean, I think bipartisanship in this area is so important because we need to probably do a bill like this every couple years, actually. I mean, it's a big, massive, complex system that always has going to be needing some attention to improve. And so we better get going, do something like this hopefully soon, and then do another round in a couple years. And you're just going to have to keep at it and keep at it and keep at it to keep improving the system for the public. Which brings me to the question on the individual market. Let me summarize quickly what we're up to. We propose in here to do a federally funded, state-administered reinsurance program is one first step. Many states have moved forward on their own and gotten waivers through the federal government to do state reinsurance, and it's shown that it's been beneficial. Premiums have come down quite a bit in the states that have done it. It makes sense that this policy has now been tested and shown to work, and we ought to sort of just nationalize it and make this a priority, because it will improve the situation for people in the individual market quite substantially. And then to the point about affordability, we propose in here something that has sort of two parts to it. One is to take the premium credits that are available up the income scale a little bit farther. I mean, if you look at the pressures that are on people, it's really that, as you move, people who are below about 250% of the poverty line, it's not perfect, but they are pretty heavily subsidized and are enrolling quite substantial numbers into insurance because of their ability to get something they find moderately affordable. It's a little bit farther up, you could start to see where the numbers are really challenging for people at those income levels. And so we propose to go ahead and take the credits up to 600% of the federal poverty line. And, but in combination with that, try to also create a new floor that says anybody eligible for a credit will get at least a minimum of $750 per person in the household. So you multiply that across a few people in the household. In some circumstances, that'll turn out to be more than what they would get under the premium credit system. And so we have that as an affordability. Again, that's just more subsidies. So I agree with everybody who's made the comment we need to do a lot more on the cost pressure side. I'd emphasize that this policy is probably one of the more expensive ones in the plan, and as a group we've agreed, because Bill Hoagland is leading us in a lot of ways, that this is going to be a fiscally responsible plan. And so even more than that, it's going to be modestly beneficial fiscally, that there's lots of money in healthcare already. The last thing we need to do is move it further up. What we ought to be doing is trying to discipline it and distribute it better, and certainly that is absolutely the intent of the policy. Now, last point that Sheila brought up was auto-enroll. This is something I think there ought to be a lot of bipartisan interest around. If you think about it, we have 30 million people in the United States that are not steadily enrolled in health insurance. There's some churn going on, but it's about 30 million people. And more or less 2/3 of them, at least, probably more than that, are already eligible for coverage. There is a gap out there in the United States, sort of the Medicaid gap, people that didn't expand. But beyond that, many of the folks that are uninsured are already eligible for explicitly federally subsidized insurance. And so the first step ought to be, well, what are we doing to try to make sure they get into the coverage in a way that's stable and secure? If you say this to the public, I think a lot of people in the public often say, well, why don't we fix that first before we go on to move on to create another program? And so let's make sure that the people that are already eligible for something get enrolled as easily as possible. And auto-enroll is complicated, but it can be done much better than it is today. We propose in here to start at the state level, authorize them to get going with it, use federal data to support it, see how it goes, and then expand it from there. There are a couple of states that are very interested in the idea, and I think if this is something that is worked at, you could end up with a lot more people getting into coverage for very low premiums at hardly any expense to both the states or the federal government.
Thank you, Jim. We're going to come back to the private market because I do want to touch on the employer tax credit, which is also an element of the proposal, but I want to briefly turn to Medicare. As was mentioned in the opening remarks, the desire to move away from fee-for-service towards value and begin to rethink essentially how we finance services. And we talk about moving to a value-based system. And I wondered if Gail might comment on that, and Jim as well, and Andy if they wish, what it is we intend and what we hope to achieve.
Well, let me start by saying we want to make sure, as people going into Medicare are making choices, that they have good information available. We can't expect to streamline and improve how providers are paid if we don't have informed seniors making choices going in. So one of the things we want to see is to make sure there's information available that talks about the traditional Medicare program, that talks about Medicare Advantage, that lays out for individuals what the choices are. The Federal Employee Health Care Plan has been known for doing this for a number of years, and we need to make sure it's as readable as some of those assists have been, and that you also don't have to wait to page 57 or something in order to read about Medicare Advantage, so that people understand their choices. They need to be able to satisfy what the seniors want to do. But we certainly want to go ahead and really push, or at least facilitate, the move from volume to value. Now, we have used that term now, at least in Washington, for a long time. And the simple idea is to say, if you only focus on reimbursement per unit of care, or if you only talk about what's available per unit, it's hard to get people to think about value. We need to unleash the provider community, the clinicians, institutional clinicians, and individual clinicians, to be able to seek out providing value and to be able to be rewarded for doing that. That means making choices available that haven't been. It means opening up some of the restrictions on affordable, on the ACOs, the Accountable Care Organizations. It means facilitating what us economists and others call two-sided risk. That means that you can both do better if you save and face penalties if you spend more, to make it balanced as we go forward. The anti-kickback, or the so-called Stark laws, have been around for roughly 25 years, more maybe. And these need to be modernized to reflect that we've had a change in some of the models that we have going forward. We need to make sure that barriers that have been put in place, always with good intention, don't stop competition from coming in. And particularly in terms of some of the generic drugs, we have to make sure that there aren't payments that are made in order to facilitate barriers being put up, so that you don't have payments to delay entry of generics into the market. Generics are certainly not the only answer, but the nature of having a branded drug is you've granted a monopoly to someone for a period of time. You do that in order to encourage investment in high-risk industries. But on the other hand, you want to make sure that you don't keep that going longer than necessary, and that you facilitate competition in these markets. It's a theme I think you have heard and will continue to hear throughout this morning, which is one of the ways that we have come together in recommending, irrespective of our different backgrounds, is that encouraging competition in markets where, for one reason or another, it has been muted, will help us, while we recognize it's not the only answer. We have to get increased subsidies out, particularly for those who've been left out. But it's an important first step, and again, one that I think all of us can hear Alice's words reverberating in our heads as we talk about the importance of doing that.
I'm going to go from Medicare to Medicaid. We didn't hear anything last evening about Medicaid, but the issue of Medicaid has been swirling for some period of time, and essentially flexibility for the states moving in a variety of directions to allow that flexibility. Jim noted a couple of areas in the context of private insurance and the markets. But one of the issues, not surprisingly, that came up in the context of our discussions was the movement to a block grant. And you'll find that there is no reference to a block grant in our proposal. And I wondered if Cindy and Jim, who were quite engaged in that conversation, may want to comment. As I said,
there's a
there was
surprise.
strong differences of opinion on a variety of issues. But Cindy, did you want to comment
Sure.
about some of our discussions?
Sure. Well, let me start off, which I think is so much a theme of this report and this event, is to first note the agreement on a pretty contentious topic, which is Medicaid. There was agreement among this group that Medicaid is an important, critical program, and that in many respects it needs to be strengthened. And you'll see some proposals in the report that would do that. For example, to allow states to continuously cover adults, regardless of fluctuations in the course of the year, to reduce churning and to make sure there's continuity of coverage, continuity of care, a new option that would be available for states. There's also a proposal to have federal investment in boosting payments for primary care providers in the Medicaid program. So there was agreement about the importance of Medicaid and really strengthening that coverage and being able to improve access for the program. At the same time, as Sheila noted, there was a vigorous debate around caps. Now, I will say, I believe, and Jim will keep me honest on this, we didn't really debate block grants. Pretty much whether people uniformly felt like there was not going to be agreement or people uniformly felt that they weren't good policy, they really didn't come up. We had a vigorous debate around per capita caps, around limiting the funding on a per person basis. Some of us felt that Medicaid, because it is really the lowest cost insurance program right now, and some might argue underfunded, that while there was an interest, as reference to our urging by Bill Hoagland to be very conscious of budget deficit, to think about how to bring down costs, that's really not the problem in the Medicaid program. It's a big program, it's expensive, but on a per person basis, it's not. So some of us certainly felt that putting a cap on the amount of federal dollars that would be available to the Medicaid program to states would further squeeze access and damage a program that is serving such an important function. Others felt very differently, largely on the fiscal side. So in the spirit of coming to agreement, we essentially decided to put caps aside. It is one of those areas where we could not agree. And so we had long conversations about the topic, and then long conversations about could we put it aside and could we agree to disagree. And we did do that. And so I think the takeaway in many respects is what we can agree on, which is really the importance of the program and strengthening it in many ways to improve coverage and access.
Jim, I'm going to allow you to comment, but then I want to move back to private coverage and talk about the employer-sponsored tax credit. But why don't you go ahead on Medicaid?
Okay, well, on Medicaid, I think Cindy is exactly right. There were sort of different points of view, so that's good. And I'd say this about how to think about Medicaid. From my point of view, and I may not fit totally in with sort of the Republican-type view on these things, but I think there should be an acceptance amongst Republicans generally that there really is no alternative to Medicaid as a safety net program, right? I mean, so the idea that there'd be some new thing invented to give people health insurance when they have extremely low incomes is completely not realistic. And so this is going to be the nation's safety net insurance program. The question is how best to run it so it serves the population as well as possible in a way that promotes all the objectives that people want to impose on Medicaid. You know, there are numerous things people want the program to do. We couldn't come to full agreement about how to do some of those things. And so we did the best we could. We came up with some ideas, and I think, frankly, thanks to Andy and Gail, they had written a compromise piece on Medicaid some years ago that we just sort of picked up and used as the basis for moving forward on some constructive reforms. And, you know, redirecting some money as well as possible while being attentive to all the things the program has to be attentive to toward better uses of some of the funds that are being paid through the program today. to improve value, improve outcomes, have it become a more accountable program in some ways. I think those are all good, and we were able to come to an agreement about how to do that. So look, I mean, I think here, this is one of those areas where the country is just going to have to continue to grapple with some sharp political differences about how to do this. I would say to my friends on the Republican side, though, they need to do it in a way that understands that Medicaid is going to be the safety net insurance program, and that means they should be promoting it as a safety net insurance program, make sure it's run as well as possible.
And then I want to turn to employer, but I remind all of you to write your questions on a card if you've done so, and to raise your hand, and we have a team of troops who will collect those cards, and we'll turn to those in about 10 minutes or so. But Jim, talk about the employer-sponsored insurance tax preference.
I get all the best ones.
Yes, you do. Yes, you do.
So
By
look, I
intention.
mean, as Senator Frist already noted, or was it Senator Daschle? I forget. One of the senators mentioned already in their opening remarks that there was, wide bipartisan agreement this is a terrible idea. So here we are in the Bipartisan Policy Center trying to pick up the pieces after Congress just repealed my favorite provision in the Affordable Care Act, the Cadillac tax. So why is it important to address this? I think, as was already stated, that, look, I mean, one employer on their own can't really do this on their own, because when an employer offers benefits to its workforce, it's doing so to attract good workers. It's a good news thing. It's trying to be an employee benefit, part of their compensation package. And so naturally, there's upward pressure on it. And it's got an open-ended federal tax subsidy associated with it, so that's even more upward pressure on it. So when people get frustrated that the employer-based system seems to be undisciplined and pretty expensive and lots of high deductibles and high premiums, that's all true, but it really shouldn't be surprising given the nature of its design. We need some kind of limitation that applies to everybody so that one employer can't be advantaged over another, and everybody has to live with the same constraint. And if you do that, then the competitive market will come up to that limit but won't go beyond it, and everybody will have to find ways to make it more disciplined over time. And that means all the things that are difficult. Finding ways to move to value, having closed networks rather than open access to every possible provider, more competition, more selective contracting, maybe more scrutiny of who's paying for what. So these are tough things, but I think we can, as a country, sort of say, yeah, it's terrible, costs are out of control, and then every time we get up to the verge of actually doing something about it, walk away. And so I was happy that this group, as a group, decided, no, we need to really stick with that as a principle, despite the fact that it's not a very popular idea.
Sheila, let me just add,
Please.
because as an economist, I feel comfortable saying, yes, I know the Cadillac tax was just repealed in a very wide bipartisan manner. At the same time, say there are smarter ways to try to limit the tax exclusion that Jim just described. That is, you can say the Cadillac tax was a particularly clumsy way to try to go about doing this, because the tax was on the employer with the presumption, correct, that it would get passed through to the employee, and that might focus the employee to want to participate in some of the value type of discussions that we've just had this morning. So you can say, yes, we need to go back and review that and try to decide what is the limit that seems reasonable to encourage employers to provide part of the compensation to their employees as insurance. That is how most of the working population continues to receive their insurance, but to do so in a slightly more rational way. What we had adopted previously had some political appeal because it was a little obscure as to what you were doing, but it really didn't make much sense. The basic idea of not having just open-ended employer-sponsored insurance, since we don't have just open-ended other kinds of fringe benefits, still made sense. Let's do it in a slightly smarter but politically realistic way, which will mean trying to balance what you can sell to the Congress and the public, and what still puts some constraint in place.
Anyone else on that topic? Govik, did you want to come?
You know, one thing I might mention, Sheila, is that one area of optimism in this general area of policy is the recently issued rules from the Trump administration around using health reimbursement arrangements to buy individual market coverage. So employers now have the option of taking that unlimited tax break, but giving the dollars to the employee, the worker, to then shop for the coverage that he or she or their family wants. And that may turn out to be an even more potent way to address the value conundrum, because if you give the dollars to the worker and the worker says, hey, if I've got $5,000 or $10,000 to shop for a plan for myself or my family, and then they find a plan that's less than that amount of money and they can keep the change, that creates a powerful incentive for price competition that otherwise we don't see in the employer-based insurance market. So I think it may turn out that there are other ways to get to the same policy outcome that don't involve reform of the tax exclusion, though I do share the consensus in this room that we ought to do something about the tax exclusion as well.
We've got a few minutes before I open it up. Let's do drugs.
Let's do drugs.
You know, I'm a 60s kid from California. Can I say? We have addressed an area that has a rising interest in trying to find some middle ground. Gail touched on it in her comments. But I wondered, Chris, Gail, others, to comment on what we hope to achieve in terms of our drug policy.
More affordability. And probably, I think where there's not excessive, but absolute agreement is that we should eliminate all barriers to competition in this area, and we should rationalize and align incentives that we have in our government today for really poorly purchasing drugs for the public programs. Let me talk just briefly about Medicare, and then we'll talk about other things. In Medicare, the government today provides a reinsurance payment for very, very high-cost drugs, 80%, which is really a substantial disincentive for plans and PBMs to aggressively negotiate for lower prices, and then the taxpayer and Medicare beneficiaries pay much higher rates as a consequence. There's real bipartisan consensus on Capitol Hill to restructure this mechanism, lowering federal expenditures, creating incentives to more aggressively negotiate, plow back some savings into lowering catastrophic expenditures for seniors. And you're seeing this on both houses. Senator Frist was talking about bipartisanship. You see it absolutely in the Finance Committee. You see it on the House side as well. You see this. There's also, and another example of irrational incentives is we in the Part B program, that was the Part D program, we pay reimbursement rates on a base payment rates plus a percentage for administration, which provides a major incentives for higher and higher priced drug products to be used rather than have a flat payment. So we move in that direction, very, very consistent with MedPAC recommendations and others. Again, rational bipartisan thing that we've been talking about. I'm looking at Gail because we've been talking about this issue probably for 20 years and still have not done this. And it's long overdue that we should do this. We talk about the pay for delay policy, which is, again, Gail mentioned this previously, a financial contractual agreement between manufacturers to delay the entry of competitions in the marketplace. We have a very strong piece in this report about the strong enforcement of the so-called Bipartisan Creates Act that was just recently enacted to ensure that pharmaceutical manufacturers give samples so generics can quickly bring drug products through the FDA process. These are all sorts of examples of what we believe to be basic common sense and bipartisan policies that can aggressively address drug cost containment. There's more that some of us would like to do in this area. There was just not a complete consensus on the ability to move in that area. I want to mention one other thing that is not drugs, but is absolutely the same issue, which is this cost complexity. And Senator Frist mentioned this about the issue of the surprise medical billing policy. That we are so close to getting something done in this Congress, and if we can get nothing else done, we shouldn't have people out there who go through an emergency room situation and get exposed to an unanticipated balance bill out-of-pocket cost that has no relationship to what they thought they were going to be exposed to in any circumstances of the, in terms of interrelating to the healthcare system in the most vulnerable times. And when people say bipartisanship is not possible, it clearly is possible, and it can get done. And I'm encouraged that there's substantial movement in this area. And I hope that our validation and support of that policy will also drive an incentive and some inspiration for the Congress to stop talking about this and really start walking on this issue.
Sheila, let me just reiterate what Chris said on two parts that we don't always focus as much. One was the part B, as in boy, drugs. Those are the drugs that are administered in a physician's office or in an outpatient. And those are easier to tackle, in my view, than going after the Part D benefit. And it is requiring a consolidated billing code so people know if there is a branded drug and a generic that they're actually talking about the same. Having a voluntary Part B drug value program, which I know was raised in the end of the Obama administration. It's come up again and been embraced, as Chris mentioned, by the Trump administration. There really are areas in what has seemed such a hyper-partisan area that we are living in where we do agree, and surprise billing and at least Part B drugs seems to be the perfect example. So maybe we can get everybody who's here, everybody who's sitting up on the dais to agree. Let's focus on the areas where there appears to be a real bipartisan agreement, not just that there's a problem, but even when you look at the solution, pretty close to what that looks like, and say, if we can do that, maybe we'll begin to restore the confidence in the public that we really can get beyond this hyper-partisan period.
Sheila, let me add, you know, we talk a lot about polarization these days, right? And I think it's been stated by other people up on this stage, but it's really important to recognize that there are people in Congress doing very important and meaningful work in healthcare that is bipartisan. The Senate Finance Committee bill on prescription drug pricing reform is a great example of that. That's not a bill that every single person agrees with, but the fact that it got out of committee on a highly contentious issue with real bipartisan support is very impressive, and the bill itself on a substantive basis in its current form is very good.
I can personally comment on the importance of the Finance Committee in all of these matters. The committee in the Senate. Just a personal note. I'm going to turn to some of the questions that have been asked from the audience as well, but I also encourage you, there are mics, so if you did not submit a question, please feel free to go to one of the microphones, which are hidden. There we go. The first question. Next month will mark the 10th anniversary of the ACA, which is enacted to address two areas with enormous consequences on costs and affordability: long-term care and healthcare inequities. The long-term care provisions were not implemented. A new HHS infrastructure to address disparities was. Did the group discuss a path forward for either of these policy challenges, and what happened? I'll open it to the group, but let me comment. Let me list the things that the BPC has been involved in. We currently have a rural healthcare task force with Senator Daschle, Gale, and Chris are involved in. April report on rural issues. We have currently ongoing a discussion around access to primary care and Medicaid that I'll be involved in. We have a report in July of 20. The integration for Medicare and Medicaid beneficiaries and dual eligible beneficiaries and how that is structured will also be something we'll come out and discuss in July. We're currently undergoing a whole discussion around behavioral health. And in 2021, we'll have a task force report on the integration of clinical and behavioral health. And we are also turning to a long-term care discussion. So there are a long list of things that the BPC fully intends to resolve. But anyone want to comment on those issues? Andy?
I'll start with health equity. I think it was explicit at some times and implicit almost all the time in what we discussed. And I'll go back to some of the comments that Jim made to refer that. We have cities in this country now with 12-year life expectancy differences from one end to the other. The suburb right next to me, Bloomington, Minnesota, 12-year difference in life expectancy. And race, income, and zip code now are the greatest predictors of health outcomes. So the importance of our safety net programs is interesting. One thing I would say in a little bit of a positive note, is we've had probably the single biggest step forward in improving health equity that we've started to see over the last 5 years. And we know this because the Supreme Court allowed us to run an A/B trial on Medicaid expansion. It allowed some states to expand and some states not to expand. And we've gotten to see the results. And cancer diagnoses in the Black community, infant mortality, maternal mortality, cardiac conditions, all of those things in Medicare expansion states have shown dramatic 5-year improvements. So it's not the only thing. There's much more that needs to be done, but it shouldn't surprise us that people at marginal levels of poverty, just above and below the poverty level, who don't have enough savings for an emergency room visit, when given an opportunity to address their health care needs, makes a big step.
Let me address the post-acute.
Yeah.
This is an area that is extremely challenging because it not only incorporates medical services, but it incorporates many of the non-medical services as well, and the role of government becomes even more complex. But there are some things that go on now which are so hard to justify that we could take steps forward. For example, the public programs, particularly Medicare, pays very differently for long-term care-related, post-acute care-related services, depending on where they're provided. This has been an issue I personally know I have railed against for at least 25 years. It is hard to justify why the same service should be paid differently when it's provided in a hospital outpatient department than provided in a skilled nursing facility or provided in a home care facility. If it is truly the same service, you want to price it at the place where it can safely be provided, and then let people decide what they want to do about it. But some of these areas are so fundamental in terms of trying to get on a more sensible path forward. And so many of us, I know, have talked about at least small steps we could make in the post-acute care world while we try to get onto the bigger issues of maybe how to make Medicare sustainable for the baby boomers as they double the population on Medicare, and then maybe take on some of the more fundamental long-term care. But there are things we can do right now because what is out there just makes no sense whatsoever.
Cindy?
Yeah, let me just briefly jump in on the long-term services and support end of that continuum. We didn't focus on it in answer to the question. We talked about it a bit. We knew that there were other projects that the Bipartisan Policy Center were engaged in, but I just really want to underscore the importance of doing it, and often we end up with conversations that say, oh, it's really important, but it's so hard. But we don't have much more time to tackle this. Medicare generally does not provide long-term care, very limited long-term care. Medicaid is the primary payer for long-term services and supports. And so to the extent that we hear and we talk to some governors, former governors, current governors, about the squeeze on Medicaid budgets in their states, it is so much is due to the pressures of long-term services and supports. And of course, the demand is growing. We've got workforce shortages, we've got financing issues, we've got access issues, we've got equity issues. And it is a really important area to focus on. And for all the contention around Medicaid and how to finance Medicaid, if we could focus in on long-term services and supports and really come up with some good solutions, it would relieve a lot of pressures on state budgets as well.
I'm going to do another audience question, then I'll go to one of the mics. While contending with market conditions, one potential conflict I see is with state-level certificate of need legislation. At first glance, my concern is that while efforts may be successful in breaking up concentrated hospital markets, it will still prioritize incumbent providers and deter new entrants, thus limiting competition. The question is, do you believe this will be a potential hurdle, that is the state certificate of need laws and other state-related activities? And if so, at first glance, do you think there ought to be something done on that front in terms of state-level activities? Ovik?
I can't remember if we talked about this in the report or not, but I agree with the questioner that it's an important issue, and there are bipartisan proposals out there to address the issue of certificate of laws, both obviously at the state level where there have been efforts at reform, and also at the federal level to give a kind of challenge grants to states that liberalize their provider markets in areas such as certificate need and other things. For those who don't know what certificate of need laws are, they are laws on the books in some states, but not all, in which in order for a new hospital to be built, you have to go through basically this government approval process that's heavily influenced by the incumbent hospitals, which of course are not eager to face competition. And so these laws in general have suppressed competitive forces in the states where they are effective, thereby increasing provider prices. So there is a fair amount of interest in this topic. Again, to cite some things that are out there, the President's Choice and Competition proposal contains reforms of the Certificate of Need law. The Fair Care Act, a new health reform proposal by Representative Bruce Westerman of Arkansas, contains the kinds of reforms that I'm describing. So there are, this is definitely part of the conversation among policymakers today.
Anybody else? Yes. Question mark at the end.
I promise. In fact, I handed it up to you. My name is Michael Cook. I'm a healthcare lawyer. I'm on the Medicaid board in Virginia, and I'm helping out one of the Democratic candidates for president who has talked about a public option. I know you guys can't come to agreement on that, but has any thought been given to Olympia Snow's concept of a trigger mechanism to address those markets where you don't have enough competition? What she basically suggested was, if you have markets where you don't have either X number of plans participating, or alternatively the cost is so high, over a certain delta, that's when the public option might become available. And I was just wondering if that was anything you thought.
It wasn't something we discussed as a group, but does anyone want to?
Yeah.
Andy?
That's awesome.
Okay. Yes, carry on.
Well, as you know from Virginia, Tim Kaine and Michael Bennett have a bill that's fairly similar. And while we didn't discuss it, and I don't presume we would have gotten an agreement on it, there's a consistency with how OVIC thinking about triggers to enhance competition where you could, so that you would encourage people not to leave the states or not to consolidate in OVIC's idea. But in this particular case, faced with the consequence of pulling out of a market and seeing that would indeed bring in another form of competition, the hope is, and I think the hope in not to speak for them, but Bennett and Kaine's bill, is it will encourage people to stay in the market. And if not, you just have to put the priority and the need of the individual ahead of healthcare businesses. And that just, at the end of the day, when making a choice, I think that's where most of us come out. We may have different ways of getting there, but the hope would be that you can't leave people without some choice there.
I think
Cindy, Gail?
the issue that becomes difficult is what is the threshold that triggers having a public option. For some of us, if it's 2 or more, that may be enough to promote some competition. For other people, you may need 3 or more in order to be present. It makes it hard. It does, however, indicate some agreement that in principle, since we've all talked about the importance of competition as the downward pressure we would like to see, that if there isn't a reasonable amount of competition there, we need to do something. Of course, we think about back in our previous public policies where it wasn't necessary. It's hard to remember, but we were worried with Part D that there wouldn't be enough programs, and we had a public option. Of course, it turned out then people started worrying that maybe 45 plans was even more destructive than fewer than 2. But I think it is possible to come back and say if it is not competitive, as either the Herschendal index or some other index, can we get agreement about what a public option would look like? So I think that offers more of a possibility than we might have initially thought. It just has to be done in a very careful, narrowly focused way. But I think it is a strategy that's out there.
I'll be brief. I just want to mention that, sometimes I agree and sometimes I disagree with this notion of states as the laboratory of innovation. But as I think Jim mentioned, lots of state activity around reinsurance, and now, should we think about it at the federal level? There is a lot of activity going on at the state level on the idea of public option, and some of it is to address bare counties. Some of it is, in the marketplace or single plan counties. Some of it is to bring down prices and make it, overall for the marketplace, make it more affordable generally and more affordable specifically to certain populations depending upon what's designed. We have Washington State that has actually adopted it and put it into law, and we have Oregon, Colorado, New Mexico, a number of states that are actually actively considering it. So I think we're going to see some, and there are different issues and different problems that in each of those locales they're trying to address. There's not necessarily one purpose for a public option as they've been debated across the country. But I think we'll see policy continue to develop in this area, and that may help lift up an opportunity to move on to federal level.
Good, thank you. Question?
My name's Carl Polzer. I'm with the Center on Capital and Social Equity, and I'm a longtime health policy analyst. So I have a quick question about thank you, future healthcare leaders. Thank you for your work, your great, steps forward, and the letter you wrote. And so the first principle that you wrote, I find remarkable and positive. And I'm going to read it. All individuals should have meaningful and affordable public or private health insurance. Have. Now, in the past, when I worked with Republicans, they would say should have access to. But this is universal coverage. This is the statement for universal coverage that Republicans have signed on to. All individuals shall have meaningful coverage. How did you guys get there? Internally.
Thank you, Carl.
And I got another, and then also, second question, it's very short, I'm sorry, and easier. There's no, this very carefully, I looked through this thing, there's every recommendation, there's ways and means to get there, except for this one. There is no mechanism to get everybody into coverage.
Well, Carl, I would actually frankly disagree.
It'll shrink the uninsured, but then that's my questions.
I frankly would disagree. I think there are a number of initiatives that have been outlined, both in terms of the expansion of the number of individuals and families who will be eligible for subsidies, market stabilization plans. Essentially, I think there are a variety of steps that we propose that cannot assure, nor could anything assure, absolute coverage. Auto enrollment, as Jim described it, I think we attempted to include provisions that got at what we understood to be some of the key issues.
And we think, and we were comfortable in principle to say, we understand people need to have coverage. And we're going to try to support a variety of policies that make that more likely. That is not the same as having a universal bill available that sweeps everybody in.
Correct.
So I think it represents to us something we're comfortable saying as a principle, and here are ways that we're going to try to approach it.
Right.
So,
Well, no, we're not getting a big argument, but of course. But I think that it is significant that we say that because we know to make, whether you're talking about a big public program or you're talking about a market-oriented, you want to have people in the system to make it work. And of course, in the eyes of affordability and meaningfulness, there's a lot of definitions about what that would be, and different people would agree on that, et cetera. I do want to acknowledge that if you looked at this report and you analyzed all the policies and you said this is all we have and will everyone be covered as the outcome of this, that would not likely be the case. We would not have CBO or Urban do that. But I do think it's really important that we have these conversations where we do publicly underscore our desire to move to that direction. And remember, this was a project that was bipartisan in nature, and it was also part of our task is to say what is not only policy desirable but politically viable. And I think this is a big down payment towards that end, and it keeps everyone in the same tent. And God, isn't that something we need to do a little bit more?
yeah, let me just add on to Chris's point. Speaking as a Democrat on this group, if you didn't know that, first of all, I think you are right to read meaning into that first sentence. I also think you're right to understand that, as Chris said, we got as far, you should view this report as getting as far as 10 people of good meaning and their own strong views and experiences that all respect each other could get. And again, I think Senator Frist said it well, 10 other people could have done and gotten to a different place. This is one example. But I'll give you an example when I say this as far as we can get. People seldom talk about, when they talk about the 30 million uninsured, that 10 million of them are undocumented, right? So, if there were 10 Democrats in a room, would they have addressed that issue head on and gotten to a different answer than a bipartisan group? Possibly. But there are some issues that I think you make steps, and I don't know because I don't recall talking about it, so you may feel differently. But we don't. And then the other thing I'd say is, this is going to disappoint some people, but there's no such thing as a perfect bill anyway. Healthcare's changing too fast. Our way we're employed changes too quickly. The needs change too quickly. So you have to keep taking bites at this. And to say we can get to 60 to 70 to 80% of what we want and get to full agreement on it, versus we couldn't get to 100% agreement, so we really didn't do anything, I think is an important abject lesson for the country, because if you get 70%, you can focus on what didn't work or what gaps remain, and you can look at how to.
And I'd just add I think it is important, and picking up on the point, there's a reason it's number one. All of our discussions began with some sort of discussion of equity. I think that's really important because even in Congress, not every conversation begins that way, even behind closed doors. But what we evolved to over a period of 3 years are really two issues. The more important one, I think, is the equity issue. And the equity issue means lots of different things to lots of different people. The Robert Wood Johnson Foundation leads every conversation around the culture of health with equity, and that's health and healthcare and well-being. And I think that's really important because we didn't start with that, but we ended with that. And it's a framing. And again, everybody's interpretation is different. And it was brought up earlier, and you can see that that's where it's coming to. The second issue of why today, your question, and why does this have not just affordable access or do as much as you can, is the cost issue. Today, healthcare for your, and we went up to 600%, I think, but for your typical low middle class simply cannot afford it. And that introduces barriers which take you back to the equity issue. And that's for acute care, it's for subacute care, it's for preventive care across the board. And I think in 2020 versus even 2015 or 2010, equity is on the forefront much more, in part because of the second issue, cost. And again, we come back to cost.
Jim?
This is a big issue, so I'll try to be quick. We've already had a lot said about it. Let me just say a couple things, because I think the kind of comment about, is everybody covered? It sort of gets everybody kind of worked up pretty quickly without it. I think it's important to kind of dig a little bit deeper about what is going on here. Recall that of the 30 million or so who are out, don't have health insurance in the United States, a good number of them, I don't think it's quite 10 million, but a good number of them, as Andy said, are undocumented. And a provision that was in the Affordable Care Act excluded them from premium credit subsidies. It wasn't something the Republicans did. It was the Democratic Party, when they enacted the Affordable Care Act, said we can't, in good conscience, provide these full premium credit subsidies to people that are in the country without proper documentation. That was something that was supported by the Democratic Party. If you go to other countries, people talk about universal coverage in the UK or Canada or something, they often do not provide open access coverage to their health system for people that are not in the country with proper documentation. Now, so I'm not saying this is a good or a bad thing, I'm just saying observe around the world how these things are handled, okay? The United States isn't totally unique in this regard. In terms of coverage, though, the other thing I'd say is that there are very large numbers of Americans that already are eligible for something being provided by the federal government. And so our first priority ought to be to make sure they're in it. Why do we have so many uninsured? Part of it is because we have an enrollment-based system. That is, you don't get counted as covered until you enroll. And in most countries, you don't have to do anything. It's just an automatic process by virtue of citizenship or residency or some other matter. And so here in the United States, you actually have to enroll in Medicaid to be counted as in Medicaid, okay? And so there's a good number of people that are eligible for Medicaid, would get Medicaid if they ever had a major medical event, but aren't in Medicaid officially enrolled. Okay, so I think part of our conversation around these things should be a little bit more about exactly how to make this work better than it will in the US context, and not be too, too emotional about it. There is one very important group that needs to be addressed, and that's people in the Medicaid gap, okay? Those people don't have access to any reasonable way to get health insurance. There are about 3 million people or so in that gap. Okay, so we're a big country, 330 million people. There is a big problem. It's not right. We ought to fix it. But let's not assume that the country is just saying, hey, let's throw everybody out, nobody's going to get insurance. That's not the point of this group. Everybody should have health insurance.
I want to just make one observation on the undocumented issue, or the people who are not here on a legal basis. It is one that the states are now on occasion addressing, which I think is probably a much better way to do that. The other is, I was curious about this, and I've only been able to find one country that covers people who are not in the country legally. Among all of them, it's none of our usual suspects in Western Europe. So it's like a reminder, this issue of people who are not in your country on a legal basis are normally not entitled to a regular national health insurance program, however it is provided. In the US, I think what we're seeing pop up are states that are ready and willing to take this on for whatever reason are doing so, and it's probably for us a more likely way to attack the problem. Even if we get beyond an immigration bill, this is still going to be an issue for us.
The only thing I would say, we've all had a chance to weigh in. I think I might weigh in just briefly. And I think we all have to remember, though, that hospitals who take these cases, these patients, ultimately are going to be addressing uncompensated care. And uncompensated care is care ultimately paid for by all of us. So we're not really avoiding it by simply saying we're not going to commit to the resources necessary to pay these things if in the end of the day all we do is see higher prices and higher costs because of uncompensated care. And we see a lot of that today, and we have to be cognizant of that as we make our choices about policy.
And EMTALA says you better not turn them away.
Anyway, we could go on, obviously, for some period of time, but I just got the hook from the back of the room. Jason, would you like to wrap us up?
You did.
Mike?
Microphone. I'll just hunch. Two things I'd like to do in closing. The first is to thank our dream team for revealing the productive partisanship that enabled this compromise over the last 2.5 years. And maybe more importantly, I want to launch the next phase of this effort. As you heard today, courageously pragmatic health care policy is really part of our organization's DNA. 10 years ago, Senators Daschle, Dole, Baker, and Mitchell put together a report called Crossing Our Lines, which really provided kind of the foundation for BPC's healthcare work. Today, what I think you've seen is an effort to elaborate on those principles into what we now believe is actually actionable legislative detail. So the next phase is Bipartisan Policy Center and our action organization, Bipartisan Policy Center Action, going to the Hill, bringing the insights from the agreements and, importantly, the disagreements that you've heard today to Congress. And there's a slight, tiny upside to congressional gridlock. They got a lot of free time. And I say this with some seriousness. There's actually a rather generative moment right now on Capitol Hill with members of Congress being willing to consider a lot of ideas that don't fit neatly into kind of Democratic or Republican kind of tribal lanes. And so we plan to go there. I want to end, I guess, where we began. First, want to acknowledge Robert Wood Johnson Foundation, Kathy Hempstead, who have been fantastic partners through this exercise. Also, the BPC staff. This has been a project of the whole. There are probably 35 or 40 people who have been involved in some aspect of this exercise. But I will just note that there's a reason why there are 9 and not 2 people sitting up here after 2.5 years. And that's really great staffing. The only way you can actually bring together these kinds of ideas in something that is a fabric of collaboration is if you have patient, dedicated, creative, often tireless staff. I will not name all of them, but want to acknowledge Catherine Hayes, Marilyn Serafini, and Dr. Anand Parekh and their teams who have been part of this effort. And with that, I thank you all for your interest, and we'll be in touch.
Good job. Great. Good. All right.